Thanks for the opportunity to present this talk on contractures and hip dysplasias in the congenital muscular dystrophies and congenital myopathies. These neuromuscular conditions are uncommon and they're quite heterogeneous in their clinical presentation and manifestations. So as an orthopedist, we're more interested in phenotype rather than genotype. What are the individual findings in a specific patient? What's their current level of function? What do we all hope to achieve? And so on. Care needs to be multidisciplinary and suited to the individual. Proactive strategies are very useful in, for example, preventing contractures, whereas reactive strategies may be required to restore motion at a joint or place a hip back into the socket. So we try to develop a realistic plan based on each individual patient, and if that plan involves surgery, then a technical solution is devised to address the specific concerns. If we conceptualize things according to the World Health Organization's ICF framework, we would recognize that all patients with congenital muscular dystrophies have impairments or abnormalities of body function or structure. But certainly as an orthopedist, we don't try to fix all of those findings that we have on our physical assessment. Instead, we try to focus on participation and on the activities, whether they be of daily living or what a patient may aspire to see if we can help the patient achieve those. For patients who ambulate, of course, we're interested in maintaining function or achieving better ambulatory function and or addressing any symptoms such as pain. A number of different treatment strategies can be utilized, and orthopedic interventions are a part of an overall plan in many patients. For patients who are unable to ambulate, the question is, can we achieve some degree of upright mobility with or without any type of a brace or an assisted device, or can we improve seating or positioning as well as comfort and ease of care? And again, there are a number of different strategies, non-operative and operative, that can be brought to bear on improving symptoms and function. Contractures represent loss of motion at a joint, and in this clinical setting involve progressive scarring within the substance of the muscle. Certainly positional influences are important. For example, if you sit in a wheelchair all day with your knee flexed, you're going to be more apt to develop a contracture where you're unable to fully extend your knee. The contractures in the muscle can be outside of a joint, for example, within the substance of the muscle tendon units, or they can also involve the soft tissues surrounding the joint or intra-articular. The most common contractures that we see involve flexion or the inability to straighten the joint, and these are seen at multiple locations, which can impair positioning and ease of care and upright mobility. Proactive or preventive strategies are available to try and slow down or prevent these contractures from developing, and one would be trying to have daily sessions where the joint is positioned in an extended position, for example, lying in the prone position for hip flexion contractures. Physical therapy for stretching and maintaining range of motion as well as for strengthening muscle groups is essential and really should be integrated into the healthy lifestyle so children don't look at this as an encumbrance. Orthotic devices or braces can really be helpful in maintaining the position of the joint. There are also dynamic braces available, for example, for the elbows and knees that provide gentle, constant stretch, and these are typically worn at night. The wear schedule will vary amongst these. For the sake of completeness, I show this paper. There's very little in the literature, probably due to the heterogeneous nature of the condition and the rarity of the condition and the inability to really study each of these interventions in a scientifically valid manner. At this point, there's limited data available for the efficacy of non-operative and operative measures in the congenital muscular dystrophy. So again, treatment really needs to be individualized as we collect data. There are a number of options available for surgical treatment, once again depending on functional status, and current symptoms. Soft tissue procedures aim to release or lengthen musculotendinous units or soft tissue structures around a joint to improve range of motion. Decision depends on whether these tissues are functional versus non-functional, the degree of underlying weakness, and so on. Bony realignment can also be considered in selected cases to restore movement at a joint or correct other deformities that may be impairing function. When surgical care is considered, we always are concerned with being able to mobilize the patient as soon as possible to avoid losing function. And then we always worry about the challenges with recurrent deformities owing to the same factors that created the deformities in the first place. So again, a subset of patients may benefit from surgery. The treatments need to be individualized and always aimed at maintaining or achieving function or addressing symptoms. The most common contracture at the hip is flexion and abduction, or the hip is upwards or forwards and also out to the side, and it makes it difficult to bring the thigh into the midline and also to straighten it out. These are usually the tissues or muscular structures on the anterior aspect of the hip, and these respond nicely to a soft tissue release called a fasciotomy, which has been previously developed for the use in polio, but the concepts and the techniques are the same. The inability to straighten the knee can result from contracture of the hamstring muscles on the posterior aspect of the thigh and also of the soft tissue structures around the joint itself, such as the joint capsule. A number of different strategies can be employed to address this contracture. These contractures can be treated by both non-operative and operative measures. Non-operative measures include frequent changes in positioning, physical therapy, and stretching. One can do serial casting, the use of dynamic splints which apply stretching force. And then the surgical procedures can include soft tissue procedures or bony realignment. And devices such as an external fixer can be utilized to gradually correct the deformity. Management of displacement of the hip can be a bit more of a challenge, and it will of course depend on a number of factors, including the amount of displacement, the progression of displacement, the functional status of the patient, whether or not there are any symptoms, and coexisting medical problems. And so we can look at the degree of displacement. For example, on the right side, you see two images in which the ball or the femoral head is partially out of the socket. That's called subluxated, whereas on the left side, the ball is completely dislocated or completely displaced out of the socket. Unilateral versus bilateral, and whether the patients are ambulators or not. And I think in this context, the hip dysplasia is more of a low tone or hypotonic type of dysplasia as contrasted with other diagnoses such as cerebral palsy, in which there's high tone around the hip. So the treatment is typically individualized. If the diagnosis is made during infancy, often non-operative management principles will be attempted. And if these fail and the hips are dislocated, then it's appropriate in many circumstances to try and surgically reduce the hips. This requires opening the hip joint up, putting the ball back in the socket, shortening the femur bone and fixing it with a plate as you see here, and also building a new socket on both sides. This is an example of an infant that was treated in a similar way. For older patients, again, a number of different factors will be considered when determining whether or not it's appropriate to surgically address the progression of hip displacement. In general, when the hip is partially out of position as shown here, and it's migrating and causing symptoms or an impairment in function, depending on the patient's functional status, strength, and medical variables, surgical treatment would be to try and get the femoral head back in the acetabulum. And as shown on the right, that involved a realignment of the upper femur to tip the ball down into the socket. That's fixed with a metal plate to hold it in position for healing. And then a procedure is also performed on the socket to bring the socket down to contain the femoral head. Pain is less commonly associated with hip displacement in conditions that have low muscle tone or myopathies in comparison with high tone, such as spasticity associated with cerebral palsy. The source can be a number of different things. Can be tightened or contracted soft tissues, can be arthritic changes in the ball or the socket, instability between the ball and socket, local pressure from seating, and so on. And a number of different choices are available for addressing the needs of the patient. So in conclusion, recognizing that I've covered an awful lot in a short period of time, as orthopedists, we really focus on phenotype and not genotype. Treatment is individualized, and it's based on the functional level of the patient and what goals we might have. It's based on the presence of any symptoms. It's based on coexisting medical problems, and it's done as part of a multidisciplinary evaluation. We always need to be realistic in what we're trying to achieve. We focus on maintaining or ideally achieving function, and then a lot of treatment options are available. Thanks for the opportunity to share this information.
Hi, everyone. I'm David Roye. I'm a pediatric orthopedic surgeon living and working in Guangzhou, China right now. I've had a lifetime interest in treating children's spines, and especially children with neurodevelopmental disabilities. I'm going to talk to you today about scoliosis and CMD. So we will talk today about scoliosis management and congenital muscular dystrophy. My disclosures are not cogent to today's talk. We'll talk a little bit about epidemiology and some general orthopedic considerations, and then non-surgical management of scoliosis, and then surgical management of scoliosis and CMD. We'll briefly talk about epidemiology. There are about 250,000 people in the US affected by muscular dystrophies. And the exact incidence prevalence, of course, is not known, but it's low, and we've known that. The low incidence that we just described means that there's insufficient evidence to guide treatment, and that creates barriers to evidence-based treatment of CMD. There's variability in care as a result, and most providers don't have experience in treating patients with CMD. Some of those barriers can be partially overcome by guidelines and consensus statements that are based on the literature and that help us to fill the gap. This is such an article on congenital myopathies published in Neurology. They followed 125 individuals with CMD with a mean of 10.5 follow-up. And scoliosis was present in 50 of those 125 individuals. Almost all had respiratory impairment at the time of their surgery. There were no deaths, and everyone maintained their preoperative functional status. Clinical features of CMD predispose to scoliosis. The phenotype of many congenital muscular dystrophies includes scoliosis. And maybe that's because of the hypotonia, the weakness, poor trunk control, asymmetrical muscle pull, and muscle fibrosis and scarring. In the 10 minutes we have today, we can't discuss the nuances of manifestation of scoliosis in each type, but there are many similarities, and we'll discuss those treatment similarities. Why do we care about this? We want to maintain respiratory function, we want to avoid pain, and we want to maintain physical function. What are the measures of outcome of treatment of scoliosis? We want to maintain functional level, we want to maintain ease of care, prevent pain, prevent complications, we want to maintain quality of life, And actually, the outcome is not the appearance of the X-ray. Non-operative treatment includes positional curve control. The physical therapy can be invoked for flexibility and mobility, in-chair positioning devices, of course, with wheelchair modifications. The total contact soft spinal orthosis may delay progression, thus surgery. And bracing can improve functional stability and maintenance of body position in the chair. Many braces have been developed to accommodate comfort and respiratory function and GI nutrition. Non-operative treatment includes the TLSO, and here are some examples of those devices, including the Garchois brace, which operates by distracting between the cervical spine and the pelvis. What are the indications and prerequisites for surgery? Is the child in good health? Is the nutrition status and respiratory status optimized? We want to perform surgery when we see progressive deformity, when there are skin problems. We always want to know what the patient and family desire. And we want to decrease the chances for the loss of physical function and try to maintain endurance. We want to preserve respiratory function and prevent GI decompensation. Pre-surgical multidisciplinary planning is a key for successful surgery. So common comorbidities need to be evaluated prior to surgery, including GI nutrition problems and respiratory problems, and more rarely, cardiac comorbidities. CMD children are particularly susceptible to perioperative complications, so we need to be on guard for airway difficulties, suboptimal pain control, pulmonary complications. Sometimes prolonged recovery times can result in deconditioning. Malignant hyperthermia is also a problem in certain kids with CMD. Scoliosis may worsen respiratory function, leading to thoracic insufficiency syndrome. This is especially important for certain mutations who have a higher risk of respiratory problems. And scoliosis is definitely more common in children with axial weakness. We know that development of the spine, thorax, and cardiopulmonary system are intimately related. As the chest wall grows, so does the lung, and the cellular growth of the lung actually peaks and ends at about age 8. So that lung, spine, and thoracic growth are asynchronous. And age 8 represents the completion of lung parenchymal growth, but only 50% of the growth of the chest and the spine. We also know that lung function deteriorates with curve magnitude, and measurable differences in pulmonary function start with relatively moderate curves. We also know that thoracic height is important to pulmonary function, and patients with spinal height of greater than 17 centimeters have better lung function than those who don't. The surgical decision algorithm is clear. We need to observe patients every 6 months with x-rays. We need to evaluate the bone age or physiologic age. We need to consider using a spine brace for curves between 20 and 40 degrees, and consider surgery when the curve is greater than 40 and likely to progress. There are strong indications for surgery when the curves are progressing and are in the 50-degree range. The trajectory of the curve, progression, is just as important as the actual measurement. What can we do? Halo traction may be used in certain severe curves to correct the curve. Spinal fusion, growing rod surgery, and pelvic fixation. The halo traction is indicated to try to correct preoperatively the severe curve. Contraindications are problems with the cranium, the skull, and complications include loosening and pain. Posterior spinal fusions are the gold standard of treatment. They correct the kyphosis and scoliosis, and the indications are curves over 50 degrees that progress or are interfering with sitting, and generally in patients greater than 10 years of age. stable nutrition and medical status. This case series describes 10 patients with CMD who had very good 2-year results with good correction and maintenance of correction. Correction and fixation to the pelvis helps to increase stability. It corrects pelvic obliquity and can avoid postoperative kyphosis. Growing rod constructs, or growth-friendly instrumentation, are an important addition to the armamentarium. They allow continued growth of the spine. The indications are in skeletally immature patients, usually less than 10, and we want to maintain their seated height and prevent progression of the curve, and to preserve pulmonary function and thoracic volume, which can be impaired by early fusion. Magnetically controlled growing rods, MCGR, use external manipulation, and that obviates the need for repeat surgery. Frequent expansions can approximate native growth, and it can avoid repeated surgery, which has the potential of creating PTSD. MCGR early results were favorable with reduced numbers of surgery and comparable curve correction, but late results revealed some mechanical failures, concerns about metal debris, and concerns about the ability of the rod to deal with a very stiff curve. In March 2020, these concerns led to a recall that's since been rescinded. With traditional growing rods, I could leave them in, but not with Magic. This is a brief case presentation of a 5-year-old with progressive curve despite bracing. And we can see that the correction was excellent in both the frontal and sagittal plane with the growing rod system. Traditional growing rods allow us to leave them in. The Magic cannot be left in place. This is a patient who went from a 65-degree curve to a 30-degree curve, and now we're faced with the decision: do we remove and do a posterior spinal fusion? With Magic, that would be necessary. But after 7 years with this traditional growing rod, the spine is autofused, the implants can be left, and the patient can be followed. Magic patients are not free from the usual problems. This 8-year-old male had a coronal curve of 70 degrees and had bilateral rod fractures a year post-op, so revision surgery was planned. This and other complications prompted us to write a paper on MCGR results, and they do degrade over time. Our research revealed 1 year from implant that unplanned return to the operating room was 40% for MCGR and 20% for the vector cohort. So our goals of intervention for all of these systems is to prevent pulmonary, cardiac, and gastrointestinal complications of progressive scoliosis and to avoid early spine fusion. We want to control correct deformity and allow and encourage growth of the child's spine. We want to avoid complications, neurological infection, implant failure, and frequent surgery. Answers to these questions will come through constant evaluation and more clinical research. You may have heard of growth modulation or vertebral body stapling. Early results were described as promising with big success for small curves, but this was designed for idiopathic scoliosis, not for CMD. Vertebral body tethering, first introduced in the US in the early 2000s, can result in correction of idiopathic scoliosis. It's been heavily marketed as a minimally invasive and better than fusion. It's been heavily adopted with increasing complications because of poor patient selection. But keep in mind that lung and chest cavity have to be penetrated, operated through to get to the spine. And there's lasting injury to the visceral and parietal pleural, the lining around the lung. This technique is not designed. It is designed for idiopathic scoliosis and not designed for neuromuscular conditions like CMD. Summary, our specially designed bracing may enhance function and delay progression and thus delay definitive surgery. Traditional growing rods, MCGR, and fusion are the surgical alternatives. Surgery is performed to stop progression and to preserve function. Stapling, growth modulation are a problem because they're designed for idiopathic scoliosis, not CMD scoliosis. And tethering, vertebral body tethering, is currently not for CMD. The need for anterior surgery through the chest wall is problematic. Remember, new is not always better. Think, study, and understand why we're adapting new technology, and don't engage in the triumph of technology over reason. I have a view that as a lifelong care provider, caring for patients from childhood to adult life, that I didn't do enough. My only regrets are not doing more. I hope you enjoy the rest of the meeting. Thank you from my perch in Guangzhou.